My introduction is going to be brief for the sake of time. I would like to welcome you all to this webinar on primary care service delivery during and COVID time. What is interesting about this webinar is that it's combining pillars of primary care, WONCA, WHO, and public health. And in order to combat the epidemic of COVID, we need definitely primary care. We also need the input of primary health, public health. Now, what is also interesting about this webinar, and I thank Dr. Salman Rawaf for it, is that East meets West. We're having EMR meeting Europe, and this is also exchanging experiences, and that's, I'm sure, is going to enrich the discussion. As I said, I'm not going to dwell much on the introduction, and I would like to welcome our first speaker, Dr. Hassan Salah from WHO EMR. Now, Dr. Hassan Salah is the primary healthcare regional advisor and access to health services. He is a team lead East Mediterranean region, regional office WHO. He is a medical doctor with a master's degree from Harvard School of Public Health. He's going to talk about the countries and regional experiences. The floor is yours, Salah.
Thank you, Dr. Jinan. Can we share the screen for the PowerPoint presentation, Dr. Ali or Shido, from your side, please? Good. Can you put it on presentation mode, please? Thank you. Thank you very much. Thanks again, Dr. Jinan. Assalamu alaikum, hello, and good evening, colleagues. As you may already know that approximately 81% of the COVID-19 cases are mild and moderate, which could receive care at home, mainly to self-care to improve the symptoms, or to be treated at primary care facilities. Strong primary health care under such condition can be critical for dealing with majority of the cases at a local level, and of course to educate people and the communities. In fact, overlooking primary care service delivery under these circumstances will add burden on the hospital with devastating results for the inpatient sector. In my presentation, I'm going to focus on 4 topics. Next slide, please. The 4 core primary health care function in COVID-19, regional successful experience at the early stage of the pandemic, challenges facing primary health care, EMRO primary health care unit recent work plans to overcome of these challenges. First, what are the primary health care core function in COVID-19? Next slide, please. Primary health care has 4 core functions. First is to maintain the country essential health service, which is considered as a top priority function. In addition to this, primary care facilities has to deal with the pandemic in terms of prevention, diagnosis, and the management of the mild and the moderate COVID-19 cases. Let us first talk about the priority function of the primary health care, which is the maintaining of the essential health services. Next slide, please. Evidence from previous epidemics has demonstrated that neglect of the usual care can be easily unintended consequence of prioritizing the emergency response and resulting in increasing morbidity and mortality related to other causes, which means that we need to maintain the usual care in addition to build our capacity to fight against the current pandemic. First, the country needs to develop clear guidelines to identify the healthcare service to be maintained. This should be developed based on the local disease burden and the country health system context. Second, is to maximize the home and self-care. This is what we call it sometimes non-institutional care. Third, you need to decrease the average daily referral for the non-COVID patient to the hospital, simply because the hospital already overloaded. In addition to ensure the readiness of the primary health care facilities for the expected increase in demand, because several hospitals and their outpatient clinics are already fully dedicated to the pandemic. And then the last action is to adjust the service provided in the context of COVID-19, and I will talk about this later on. The question is, do we have successful examples from our region on maintaining the service delivery of the essential service package at the primary care facilities? The answer is yes. Foreign presents the country's early response to the pandemic back to March and the early April of this year. Next slide, please. Morocco and Pakistan, they issued ministerial circular on the role of the primary health care at the beginning of the pandemic. Iraq identified the essential health services. Bahrain and Saudi Arabia, primary health care facilities were fully functioning with encouragement of the online consultation. Palestine, through the NGOs and UNRWA, provide an important role for maintaining of the essential health service. Tunisia, the central government provided guidelines for the continuity of the essential health service. But we have to put in consideration that the people are likely to present before having confirmed COVID diagnosis. And there is an expected overlap in the patient flow for the services directed to COVID-19 and the other essential services. So before we move to the next three core functions of the primary health care, which is the prevention, diagnosis, and the management, there are certain actions you have to consider because the possibility of receiving COVID patients. These actions are related to infrastructure, health workforce, medicine, risk communications, and referral. Next slide, please. It is highly recommended to screen all patients on arrival, to have a separate waiting area and a clear patient flow. There are several available online training courses about COVID-19 that you may need to register in to know more about the pandemic. And of course, the staff is to respect the standard precautions such as hand hygiene and to use the personal protective equipment. Next slide, please. It is crucial to maintain enough medical supplies and primary care team to have an access and the proper use of the personal protective equipment. You need to disseminate and updated information about COVID-19 to the community in a very simple language. Strong referral mechanism is important in the current pandemic. And we have several excellent examples from the countries in our region about their response. Next slide, please. Afghanistan, Public Awareness Committee has been established in the presidential office. Lebanon and Morocco, they conducted online training. Jordan and Djibouti provided medicine 2 months in advance for the chronic patients. Iran, they conducted distance screening. They received more than 30 million calls. Iraq, they redistributed of the health workforce duty time. Oman, they conducted early notification and the risk communication campaign. Palestine mobilized the mobile outreach teams to get the swab. What about the other three core functions for the primary health care? Next slide, please. As a brief for the primary health care facility function for the mild and the moderate case of the COVID-19, it has prevention, diagnosis, and the management functions. Primary care team should be updated, I will not say on a daily, but at least on a weekly basis on the evidence-based information about the pandemic. To encourage the phone triage based on the country-specific guidelines. The pulse oximeter is an easy to use for screening hypoxia, especially in the resource-limited setting. Mental health and the psychological support is very important for the population in the current pandemic. Countries' experience in prevention, diagnosis, and the management of the COVID-19 are varied in our region. But several countries are using hotlines, telemedicines for the counseling services. Next slide, please. Djibouti, Iran, Jordan, among several countries, established hotline for the counseling service. Lebanon, they developed appointment system. Telemedicine in Oman. 270 psychiatrists participated in the hotline support in Tunisia. What about the many challenges currently facing the primary health care? Next slide, please. In my view about the challenges facing the primary health care, that it is the nature of the pandemic in one side, and on the other side, primary health care was not well equipped in the beginning in terms of enough trained human resources, good referral mechanism, availability of the national guidelines. In many countries, actually, the policy maker didn't have a clear role about the primary health care at the beginning of the pandemic. In many countries in our region, experienced serious interrupted access to the health services at the beginning of the COVID-19. And this leads to more than half of the planned non-communicable disease screening program have been postponed due to the COVID-19 in the region. In addition, some countries, they ignored the major role for the private health sector at the beginning, and it ends that the pandemic simply overwhelmed the public health sector, and it turned to the private sector for additional capacity as a part of the country planned against COVID-19. To overcome these challenges, next slide, please. Besides several initiatives and publications from the headquarters primary health care unit in EMRO, drafted the interim guidance note under the title of Role of the Primary Health Care in COVID-19. It is directed to the policy maker. Actually, my presentation is summary of this guidance, and to support the primary care working teams in implementing of this guidance, EMRO worked with WONCA, UNICEF, UNFPA, UNAIDS, UNHCR to develop an online training under the title of Role of the Primary Health Care in COVID-19 pandemic. The web format and the mobile application training will be launched, inshallah, during this month. And to implement the headquarter operational guidance on the maintaining of the essential health service, we are working with the member states to identify countries' mechanism based on the recommended 10 strategies for the operational guidance. The last activity is to raise a policymaker attention about the potential role of the private health sector and to promote the government's efforts for the effective engagement against COVID-19. Thank you, colleagues. Over to you, Jinan.
Thank you, Dr. Salah, for this very interesting presentation and the brief presentation on the regional experiences in fighting COVID and in primary care. Now, I would like to move to Europe and know about their experiences in fighting COVID in primary care and the role of primary care in addressing this issue. And would like to welcome my very good friend, Mehmet Ungan. He is one of the founders of the Turkish Association of Family Medicine 30 years ago. He doesn't look that old. He is 2 times president of European Research Network and now of WONCA Europe president. He's an academic professor of Ankara University, Department of Family Medicine, and he has 34 years of experience in family medicine. Mehmet, you're...
Thank you, Jinan. Very kind of you that you have been summarizing. And I have another privilege that I am a good friend of Salman also now. Thank you for giving me this opportunity together with to be with you all. I think that will be a great initiation of a very good collaboration, adding to our friendship for the last 1 or 2 years. Actually, Jinan, we have been working together, but I am very eager to work with the other colleagues also. Now on the screen, I have been seeing Ali and Tawfik and Hassan. Already we started to collaborate, as I see. And I will try to share my screen, I think, and if the administration lets me to do that. I think screen, yes. Where is the that one, I think, sorry. Is for the green one, I'm just checking the screen, and now Zoom start broadcast. I think it's is that the one? I'm not sure. Can you see my screen?
Yes, yes, we can see it now. Yes, the key messages in the pandemic. Yes, yeah, exactly.
Okay.
This is your first slide.
First slide. Okay,
Yes.
Thank you.
Yes.
So I will try to be very short, because those kind of experiences are everywhere in all regions we have been seeing. But I will just try to share some opinions, maybe some kind of happenings in the Europe also with you, because those are two different regions. But Europe is really very diverse, and we have 47 country members in Europe. So that means we have influence of the Nordic part, we have influence of the very Western, and we have influence of the Eastern and also Southern countries. So we have common, in some part of the Europe also, we have common culture, let's say, together with the EMRO region. And you know how the regions are made in WONCA. It is depending on the WHO regions of the world. So although like Turkey or UK, some countries, Norway, they are not in the European Union, but still in the European region, because they are included in the WHO Europe region. So that's why we are inside of it. Now, I have been trying to discuss with my colleagues in the last 4 months. You have all of us changed the style, and before I was not. You wouldn't see me without a tie and formal dress in such kind of conferences. And now it's different, because we have been used to have such kind of Zoom conferences. Salman was saying that we have to adapt ourselves. Yes, we adapted, but also I have changed my style because of being unavailable sometimes to find the dresses or just to be informally to address the conditions. And we are trying to see the future. What will happen? I don't know. Nobody knows well. But I think as general practitioners and family doctors, we are so close to the public, and we are inside of the public. We are not living in the hospitals. We are living in the population, in the public. And together with the public health officials and workers, let's say, we are a part of it, and we should foresee. We shouldn't. Maybe we can't foresee the future, but I think we should try to enable it. And this word is taken from the Little Prince, if you know that book from Saint-Exupéry. And I think this word is something, and I would like you to encourage you to read this Little Prince, because there are a lot of very nice words. Yes, if I made some mistakes in the Arabic letters, please forgive me. And those are the key messages in the pandemic for the family medicine across Europe, actually. And like other regions, the family doctors across Europe played an essential role in the last 4 months, combating pandemic and securing the public health priorities. And the other message I can tell you that the rapid and successful implementation of the telemedicine and remote care model really did something in clinical practice in the family medicine, in general practice in Europe. And the third message could be the medical education and research in family medicine was totally affected and maybe accelerated to change the directions. I can tell you, maybe I will not go on all of them, but those are the items which we would emphasize as the WONCA Europe to our primary healthcare teams and family doctors. The new research agenda should be also including those kind of questions, and we have been discussing it, and I think we will publish it. You can maybe read from the slides later. But there are a lot of small items which are raising from the practice of the general practitioners, and those should be answered by the research also. And I can tell you what strongly influenced the approach used in family medicine in Europe. There are 5 items really influenced the approach. The availability was important for the personal protective equipment. If you remember, we were trying to advise all people to use the personal protective equipment in the primary healthcare services. But the colleagues from Italy turned to us and told us informally, saying that it is not possible always. You cannot, because we don't have it. And it was the beginning of the fight, and they were so correct. We were hesitating to advise everybody, but we were not advise, but to make it mandatory, because it was not possible for them to find those equipments, although the government was trying to supply. Still, it continues, but the availability of PPE, personal protective equipment, really influenced. Complementary tests. You will see in the coming slides, I will show you a kind of statistics, and approximately 27% of the countries still do not have the test in the primary healthcare in Europe, in the very much developed Europe. So the chest X-ray and easy and open access of the chest X-ray, sometimes the tomography was also kind of influencing factors. User-friendly remote health services in primary healthcare. And also, we should have been continuing the training for the new doctors. As you all know that, we have been having new graduates, and even the interns started to use, started to fight together with the other doctors, family doctors. The interns also started to be included in that kind of COVID polyclinics and the fight. So I think the blended training, both for post and undergraduate family doctors, was at most important at that time, and still. I will not go on all those slides, but I just wanted to, you can read all of them, and I will be happy to answer some of them. But I think the most important thing is knowing those 5 elements going to the success. It was written by Michael Kidd, who was a brilliant president of the WONCA, and still a collaborating center, I think the head of the collaborating center in Canada is originated from Australia and New Zealand area, let's say. And he's a very influential scientific person. And in the British Journal of General Practice in July 2020, I had his remarks, and I think he has written 5 elements for success. What was that? What were them? One of them was protection of vulnerable people and provision of treatment and support services to affected people, continuity of regular healthcare services for the whole population, and protection and support of the primary healthcare workers and primary care services, not only keeping the system, not only keeping the doctors, but also really protection, because the violence increased also in some parts of the Europe. and provision of the mental health services to community and the primary healthcare workforce. So those 5 were proven, according to him, to be key elements for the success. And also, I would just, because Hassan already made a very good presentation, I think it would be very nice to discuss sometimes the culture and the community, and also community engagement in the first line of defense in the battle against infectious diseases. So how the community reacts is also very much depending on the culture, religion, and tradition. And those all affects the prompt community response in the regions. And I can tell you that it is not easy to keep in harmony and conformity to society's ways. And if you look at the Europe, as I said to you, it's diverse. And when you go to the western part, I mean, the very western or central part, or if you go to the northern part, they are completely different than the other parts of the Europe, and which is really affected by the traditions and the religions and the families and such kind of cultures. West legalism is most likely to be the truth, and but on the other hand, we are depending on our other specifications, very warm relations and strong family ties, larger families, size of the household. And also, like in the United States, our regions also have all or nothing phenomenon. That means if we are trying to normalize our countries, and if we announce it, the next day they are normalizing too much. And then you have to go back and just to make the same fight again and again, because the cases immediately increases. So what we aim to normalize is not the same what the population understands in the televisions when we are talking, saying that, okay, now we can open the shopping malls, or we can make the those kind of travels, or you can start to work, or schools, for example. And most of the countries are opening the schools, but that doesn't mean that everything is normal. And those personal protection rules and the measures should be continuing, but in our countries it is not like that. So the younger are the more mobile, and immediately they start to socialize. From young to elderly people, more than 60 years old, the infections are easily coming to home, invited to home, and it is not easy to fight in those cultures. Sometimes advantage, sometimes disadvantage. Because in the Eastern culture, also there is a culture of the culture and religion tradition have, such kind of respect for rulers, for the family, for the social harmony. So that means that if the government says, okay, don't do that, be careful, they are really, respecting it. Especially the very far east of the world is like China, like Ungan, like, when you come from there to here. So you can see that they are obeying the rules much more than us. But we are obeying the rules also, until when the normalization starts. That we have to consider. It's not same everywhere. I just want to remind you 6 core competencies for the education of the family doctors. Any family physician, any general practitioner has those skills, 6 skills: primary care management, person-centered care, specific problem-solving skills, comprehensive approach, community orientation, and holistic modeling. All of them, 6 of them, are and were very important in the fight also. I would like to thank to EURACT, which is our WONCA Europe's European Academy of Teachers organization, and say that it is the educational network of the WONCA Europe. And they immediately acted, and they have council members. They immediately make this survey very quickly. In 20 days time, they got the answers. They will publish it, of course, but I get the permission of them just to share with you some of them. You see this is a map of the Europe, and including the other countries out of the European Union, but the WHO region Europe. And you can see from 0 to 10, the national control degree of the COVID-19 related health services. From 0 to 10, full control is 10. So you can see now France, Italy, Greece, Bulgaria, those countries have really a very strict and very high level of control. And if you look at Turkey, Norway, and UK, and those countries, Portugal, those countries are also high level, let's say 9 or 8 grade. But some countries have, a lower level of control, the national control, like Ukraine and some of the others. We didn't have any information from Spain, so they skipped it also. And those are 33 countries. So I would just like to summarize a few items for your attention. And 93 of the 33, 93% of almost most of them, of those 33 countries have phone triage. It is an important thing. And 27 of 33, approximately 80%, have video consultations in practice, in general practice. And 73% of them see patients now, still see patients now, but 45% of, less than half of them, doing home visits now, and less than half of them have arrangements for palliative care, people with the C19 at home. So among those 33 countries, 20 are using retired family doctors, mostly in phone triage. But if you see on the right side, the yellow colors, like in Turkey and some other countries, still 27% of the countries cannot test in the general practice. 24% of the countries have COVID suspected patients in the practice, they can see them. But while 85% are in special COVID-19 specific hospital services. So it looks like that we are fighting, but we are not seeing every case as we see. Thanks to EURACT for the permission. So what is going on? Why the workforce is an ongoing need? So that was always like that. In the primary care and public health and primary health care expert meetings, it was always emphasized that we should expand the primary health care team to deliver public health services much better. But now it is more than ever. New working styles and roles were also discussed at that time. Let's say 4 months ago, we were discussing it in Bled, if you remember. But now you can see that it was correct. What is the outcome of this expert network is correct, because immediately after that, we have seen this pandemic, and it is important. Non-registered professionals are important, and the support and guidance is very important. We have to plan them. Clear understanding of the roles in primary health care, the limits, responsibilities, those are important. But not only, also a coordination is needed to have a sustainable primary health care services, especially in this pandemic. The most important thing I have always emphasized, the importance of including the family doctors and the primary health care and public health into all decisions. not only in pandemic, in primary healthcare decisions, we have to have a kind of word. So I can just, I think, last one, a goal without a plan is just a wish. I like it. I like that word. If we want to succeed, we have to have a pandemic preparedness plan for each country, adjusted for each region, and each region of that country also. So the last thing is, I would like to invite you as the president of the WONCA Europe, if you are having a time and if you are so brave to come to the Berlin, we are very happy to see you in December 16 to 19 in the lovely Berlin, because we will celebrate 25th year anniversary of the WONCA Europe. Thank you for including me in this very live, very nice discussion. Thanks, Jinan.
Thank you for this very interesting presentation. And if I need to summarize both presentations, it's basically talking about the role of primary care in fighting, and it is basically how to maintain the usual care while fighting the epidemic using prevention, diagnosis, and management of COVID. Now, several countries have used different approaches, but most of them, they concentrated on training, on screening, testing, training their health staff, and also on mobilizing their primary care resources. I like the idea of mobilizing the other primary care staff in order to, and using also the telemedicine and triage in order to decrease the burden of the primary care. Now, I'm sure the two presentations have are going to incite a lot of questions. And I'm going now to leave the floor to the panelists. Dr. Salman Rawaf, the president of Arab Public Health Association, Dr. Tawfik, the Professor Tawfik, the vice president, and Dr. Ali Abutiheen from the Iraqi Society of Medicine.
Thank you very much.
And the floor is yours.
Dr. Jinan, thank you very much. Thank you, Dr. Jinan. Thank you, Professor Mehmet. Thank you, Dr. Hassan. We truly appreciated what you presented. Such a rich experience and key point. I agree, a goal without a plan is merely a wish. And this is what's happening almost in many parts of the world. There are a lot of challenges to health systems now with the context of COVID. It's really a big challenge, and many countries managed to rise to the challenge despite, not being involved as part of the emergency planning team, despite the whole things, the spread of the virus and the transmission happening at such a speed, despite the quick actions which not based on plan, etc. So all in all, one can say to all colleagues around the world in primary care, well done. And we know that we lost many colleagues to this damn virus again around the world because with courage, they continued to provide services to our patient without hesitation. And that a price everyone will remember for the rest of our life and for generations to come. Let me start with Professor Khoja, and I'll come to our guest, Dr. Ali Abutiheen. I'll make sure I will not do a mistake, from University of Kerbala, a good friend and colleague with tremendous amount of experience, and I'm sure he will share with us some of the rich things going in that country, which is facing acute crisis with COVID. We'll come to that. Professor Khoja, any questions in your pocket, in your email, in your rich text with the 3 mobiles?
First of all, thank you very much, Professor Salman, for a very excellent gathering. And at the same time, this is a very excellent webinar that people from different regions, they are meeting together for the sake of our beloved citizens and people all over the globe. And second, I would like to thank also Dr. Jinan for her leadership of such a meeting, and the eminent speakers and my colleague from Kerbala, Professor Abutiheen. That is excellent. I really enjoyed the two presentations. Actually, I have two questions and I have 4 comments. Let me start with the questions. We know that the emerging of pandemic was it was a quick emerging, and it was coming out of the blue. And we understand from your presentation that primary healthcare is the core business of any healthcare system, is the center of any healthcare system. But we understand that the primary healthcare was a little bit hesitant to play a greater part in the beginning. But later on, we have experiences from other countries, as seen from your presentation. My worry is what are the determinants? You are expert people. What are the determinants and the requirements for the primary healthcare to be prepared for the second wave or similar pandemic? This is the first question. The second question, we in the Gulf region mainly, and other Arab countries like Jordan, Tunisia, and many other countries in the region, we manage chronic illnesses, NCDs, mental health, and others within the primary care setting. But when the epidemic came, these issues was a little bit given a second level of care. So how can we foster the role of primary health care in maintaining the well-being and the need of chronic illnesses, mental health, reproductive, maternal, and child health? This is really, I visit so many primary health care in my country, and I saw that they are concentrated on the COVID-19. But at the same time, there is a requirement for our the people in the catchment area. So this is the two questions. How can we prepare the primary health care set up for the second wave? And the other thing, how can we foster and maintain the well-being of our people in the catchment area of primary health care who are suffering from chronic illnesses, mental health, and maternal care, and so on and so forth. Thank you so much. The floor for you.
Okay, Dr. Hassan.
Yes, sir. In my view, the most important, outcome from the first wave, that we learned that the absence of the clear guidelines to the staff working in the primary health care was a serious challenge. So my view, we need really very clear guidelines. What exactly the role is for the primary health care in the COVID-19? So far, many countries still there is a kind of shortage for the clear guidelines. In addition to, we need to train the human resources. I mean, most of the staff at the primary health care facilities, there is kind of shortage for the training. So far, there is a lots of online training, as I mentioned, WHO with our colleagues from different organizations who are going to launch very soon an online training about the role of the primary health care for the COVID-19. These two topics, the guidelines and building the human resources capacity, I guess this is the most important, among many other things. If we are talking about, for example, the referral, the availability of the medicine, and but these are the two topics: availability of the clear guidelines, in addition to building the human resources. Over to you.
Can I have a view from Jinan, and especially you are in Lebanon, and a lot of situational issues, Dr. Jinan?
In Lebanon, we're having also, we had the training on for the healthcare staff. Now, for the primary care, the way it's delivered, we're back, but not fully to the face-to-face. Now, the peculiar situation about Lebanon is that it's not only primary healthcare, it's also mostly private. So in the healthcare centers, we're having some face-to-face, We're having screening, like already mentioned, but also we're having the private sector who is having by appointment system, the providing primary care, not only as COVID, but also the continuity of care for the NCDs and the chronic cases. Now, like Dr. Tawfik has mentioned, we're worrying about the NCD problem worsening later on. Now, like he mentioned, most of the attention has been diverted to addressing COVID, how to do testing, how to do screening, how to do managing COVID positive in primary care. But to a great extent, the diabetics, the hypertensives, the asthmatics, the COPDers, they have been more or less ignored, and their management has been put on hold. And we're seeing now more people having higher hemoglobin A1C as we've observed before, for several reasons in Lebanon, one of which I would say maybe COVID. Now, this is why the question is, my question is also to Hassan, is most of the guidelines have been, or the problems, yes, the guidelines are how to address these NCDs in acute COVID. But now we're talking about COVID going to stay, and to stay for 1 year or 2 years. So how are we going to deal with these cases in the chronicity, let's put it that way, also of COVID? That's also a challenge to be discussed.
It's a good question. I think, Jinan, we need to revisit. But let me come to our guest, Ali Abutiheen, and Dr. Ali, Professor Ali, from your perspective. I want to link that perspective into a question which came from Zainab. There is no surname. Talking about the current circumstances, and most probably will continue to live with COVID for some time to come. And the Lancet paper clearly showing that there will be a second wave in September, and maybe worse than the first wave, taking the experience of 2018. Is it safe to continue with virtual consultation? And whether in Iraq, what is the percentage of virtual consultation? Mehmet showed the percentage across Europe. So to you, Dr. Ali.
Thank you, Professor Salman. Thank you for all dear colleagues. Thank you for inviting me to be part of this webinar. It's a great opportunity for me to be with my colleagues and seniors. I meet most of you, Dr. Mohammed, first time to meet him. What we face in Iraq now is seems like we are in the peak. Actually, we are increased number of cases, daily cases, more than 2,000, and about 100 or more than 100 deaths each day. When we start at the beginning, it was simple or more easier, as the cases was very limited, just a few cases, 1-2 cases per day in each city, maybe 10s, 20 cases. But now, from starting of June, we come in hundreds, now in thousands with this. And definitely the real number of cases are much more, because the investigation is not that big. In Iraq, we have a real problem now, because as you know, Iraq primary healthcare system, as well as the health, is not that developed. It's already suffered from many problems. It already suffered from overcrowding, limited resources. Now with COVID, the situation is more difficult. A limited number of physicians also we have, and the staff working. So now in the beginning we go to the virtual consultation. We start in private and some governmental to start the virtual. We have no percentage. It do some help, but not all people contact the clinics. But it also solves some problem. But many people now, there is different attitudes. Some stay at home, will not visit unless for emergency, and other people, they just go for minor issues, still come to the primary healthcare center. Primary healthcare centers, still the programs are running. Major programs in Iraq, maybe the NCD is still working, but the majority are the MCH, and the child care is the more frequent attendance to the primary healthcare center. So we still continue on vaccination, antenatal care visits on these. And there is a danger now. And we cannot separate, most primary healthcare centers cannot separate the region for the COVID, not that.
So there is no mechanism for COVID patient and non-COVID patient.
No proper. There is a mechanism, but on the ground, it's difficult. There is no. You cannot separate almost. It's weak.
I mean, this is Ali, which Dr. Ali, cannot understand. When you talk to colleagues in the Middle East, immediately they say difficult. The colleagues which are in Europe, they didn't face that difficulty. They managed to triage, making sure to protect staff, because the continuity of primary care is so essential. I don't know what is this magic word, I can't. You know, why other people...
We can't.
Is that unique to our Arabic region? يعني ما ممكن. Impossible.
No, it's really, the situation in Iraq is maybe different. We don't know. You don't know who is the leader actually in Iraq. You don't know who is running the issue. Sometimes, so it's not uniform system. So each primary healthcare, each directorate has certain issues, different situation.
But your center, Dr. Ali, I don't want to argue much about this, but your center is your kingdom. So you should be responsible for your kingdom. Forget about the Prime Minister of Iraq and the government. Forget about that. Focus on your center. So why your center is not managed in a proper way as any center in Europe or America or Canada, you know, where and somebody will say, don't compare. You know, no, I will compare. You know, so why you control your center? Forget about anybody else. Control your hospital and manage the services in a safe way.
The problem, Doctor, it's already not organized from the beginning. Before COVID, it's not organized. We have no appointment system. People come as they wish. They already overcrowded on the physician. Until now, the patient or the client, he do what he want, what he think. He come today, so he want to be managed today. This is the problem is not new. We have to manage the previous problems.
Thank you. Professor Mehmet, can I bring you here? Because this is an important point. What we notice, I think you may have seen it in a recent paper which we written, we identified across the world 3 possible strategies in primary care. The strategy of business as usual, i.e. risk strategy. Some countries, they didn't change anything as if COVID is not there. Some countries, they closed the primary care totally. Other countries like the United Kingdom, for example, they developed a very structured way in managing patients remotely. And they didn't allow people to come to the center face to face. So both COVID and non-COVID patients. What do you think? Which strategy is more appropriate and which one should we use now? We learned a lot. If the second wave will be with us next September.
Yeah, this is not an easy question actually, because I think, as I told you, this is a kind of, if we are talking about all Europe, the traditions, understanding, and the cultures really affect the behavior. So those countries who have very high level control in the primary health care, they can manage to some certain level. But if you are not having a central control on the primary health care, it's not easy for the general practitioner just to act safely. Talking about, because in UK, maybe, I'm not sure, maybe you will see less violence towards the primary healthcare workers. But say that in the southern region, you may have more violence to them. And in Turkey, we have been seeing a lot of problems in the primary healthcare because you arrange everything. And the two services are continuing. Those chronic patients should get the primary healthcare services. You cannot stop it. If you stop it, it's not easy. It's not anymore easy to go back to the continuity of the chronic care. So that's the reason we were trying to get some measures in some part of the Europe with the government support, of course, to legalize and to make it formal way of protecting the doctors and the primary healthcare workers, but on the other hand, continuing the chronic patients because it's really important. What some countries made it very good. Some of them, the main problem was not the acute problems, but the main problem was refilling or prescribing the chronic medicine, for example, or having some small questions to the doctors, to the family doctor, because they were used to ask it to their own doctor, not to go and search somewhere else. So those should be met, those needs should be met. With those, how to say, distance consultations, teleconsultations or triage or whatever, not only for COVID, but for the chronic diseases also, it was proven that it was very effective. Most of the workload of the system was carried by that way, actually.
Thank you.
And the other way, the other successful model was separating some primary healthcare centers as COVID-free primary healthcare centers. Or in the center, dividing it, because we have group practices, for example, in Europe, many, not only solo practices, but most of them are group practices. So in those group practices, some of the physicians and the primary healthcare workers were working only COVID-free polyclinics making. So that also was a successful model. And also in each and every suspect, referring the patient to the COVID-specific primary healthcare center or to the COVID-specific hospital. So there are a lot of models which you can adapt according to your country. But in Iraq, I don't know the structure very well, but although I don't know very well, I can tell you that it shouldn't be too different than Turkey. I mean, the understanding of the people, the behavior of the people, and also the doctors, the physicians, we have very big similarities actually. So I think
I think, Mehmet, I'll come to this point. I mean, I want Professor Khoja to come in a minute, but there is a question from, let me read it, from Arij Al-Harbi. She's thanking everyone for the excellent so-and-so. If online consultation, and if Jinan can answer this, we'll appreciate it. If anyone wants to chip in. If online consultation not available, how to deal with the chronic patients or the patient with the chronic diseases? Yeah. Okay. Jinan, Dr. Jinan.
Okay, if online consultation is not available. Is available or not?
It's not available. How can we deal with patient with the chronic diseases?
Okay, there are several models that have been used worldwide. They ask people, or there are some kind of training how to take their own blood pressure, how to do self-monitoring for chronic diseases, and then they can communicate with their physician, either email or phone call and then have their medication either renewed or adjusted according to whatever data they provide. Now, definitely there are several apps that can be used. They can also be downloaded, and then they can help the person self-monitor. But all of these do need certain form of internet. Now, there's always the traditional way, which is the face-to-face, which I believe is still the best. And that gives more interaction with the people and gives a good compliance too. So I don't know if the colleagues have different input. Or,
any comments on this quick one before we go to Professor Khoja?
For me, actually, Dr. Salman, from the experience of the countries, many countries actually, they rely a lot on the hotlines, on the teleconference, this kind of things. Now, in the worst case, with a chronic patient, definitely, I mean, to send the medication a couple of months in advance for a chronic patient, it worked for several countries in the region. As Jinan mentioned, in case if there is no availability for the telephone calls, whatever, definitely face-to-face, this is the only options available. Over to you.
There is a question I'll come after Tawfik Khoja about private sector. Professor Khoja?
Yes.
Thank you so much. I am really enjoying this session, but I would like to draw to two important issues before the time is going to finish. That first of all, that we would like to highlight the importance that even we are knowing that there is a second wave, we need to ask the countries and the governments that they must equip healthcare workers with up-to-date information, with the personal protective equipment in the primary healthcare. The setup in the primary healthcare is open access. It's not like the hospital. There is the security in the primary healthcare is not like in the hospitals. The setup of the premises of the hospital is different from the premises of the primary healthcare, and so on and so forth. The accessibility, and so really this is very crucial, because there is a fear within the primary care personnel about they are open, and it's not only the guideline they need also special attention from WHO and WONCA and others to bring the attention of the stakeholder about the personal protection for the health workers. Second, that the data, generating the data and the information for primary health care is still weak. And our colleague in the primary health care, they are not very well equipped with the data. They are as a second hand. So this is not right. They have been trained on the community, and the community, they are working with the community, and they are for the community. So what I'm saying that generating the data and giving the primary health care person better data to make their decision more appropriate and more strengthful for the sake of the well-being of the community. So these two comments I would like to bring to your to our respective colleague, and I wish both of them, or the four of them, and including you yourself, Professor Salman, to highlight on this two very important issues. Thank you so much.
Thank you very much indeed. This is very, very valid point. Thank you very much. I have one question from, I think, anyway, talking about private sector. As you know, some countries locked the private sector because studies, local studies based on risk assessment, they found in one country that about 45% of the transmission are caused by private sector, especially doctor offices, not the hospital. Maybe the hospital, we don't have the data. Simply because these doctor offices, they don't have triage system, they lack personal protective equipment, and overcrowding in the waiting room. And a patient leaving the home with suspected COVID, or indeed have a symptom of COVID, going to the private sector, clinic in the private sector, he in his way, likewise to hospital, he in his way or she in her way, you know, they will infect at least 10 people, you know. So Jordan and Iraq, for example, closed the private sector for 2 weeks, you know. Is it that something which should other countries follow, Mehmet and Hassan?
Salman, I can respond for this if you allow me for this. Okay, we cannot really deal, let me repeat it again, we cannot by any means deal with private sector in isolation from the, we cannot deal with COVID-19 without joint collaboration with the private sector in our region. Private sector is providing most of the service in many countries. I mean, look for Lebanon, for example. Can Lebanon deal with COVID-19 without private health sector?
Initially,
no way.
Initially it was without.
No way. I mean, most of the services there, it is a private sector. The same if we are talking about the outpatient service in most of the countries in our region, almost 70%. Many countries, yes, as you just mentioned that at the beginning, they completely put aside the private sector, but it ends now that the public sector already overwhelmed. You cannot, they have their maximum capacity. So it ends that now they are asking the private sector, please help us, take your role in the COVID-19. But we have to put very clear guidelines how to deal with this. Yes, I understand for Jordan and Iraq at the beginning, they said, please, it is the full responsibility of the public sector to deal with COVID-19. Yes, agree with you. But later on, for the future, it is going to continue. They are, I don't think so. The public, yes, there is a kind of ceiling, they cannot exceed it. And then they have to go on for the private sector and ask their support as well. Over to you.
Hassan, I may miss my point. I was talking about clinic, not hospital. The hospital is playing role in supporting the public sector. And many countries in a clever way took control of entire private hospital, which is the right way, to be honest with you, to add it to the public sector. But here you are talking about the clinic which is responsible for 45% of the transmission, simply because they don't really have the right measures. They don't have expertise in dealing with COVID. We've seen surgeons treating COVID. It's a joke.
Yeah, I know. Yeah, about this video. Yes, I know. Yeah,
really,
I know.
I don't want to call it nothing less than a criminal act.
Yeah. Yes, yes, I agree with you on this.
Facilitating the spread of the disease. I fully understand, you see, that some government acting decisively, etc. We need to look at the private sector, and I need your comments, Ali, if you want to come in, Jinan, Mehmet, that private sector clinics should be regulated very carefully, you know? This is not about guidance, not about a guideline. Guideline is meaningless. This is about law. Under public health law, you insist that they should triage, they should really respect social distancing. That's because, as you know, during epidemic and pandemics, all right, the public health law become the supreme. Any orders coming from the crisis committee or a COBRA, they call it in some countries, any orders, these are, they have the status of law, you know, without going back to parliament, etc. Ali, what do you think?
Thank you, Professor Salman. There is problems in private sector, but as I agree with Dr. Hassan, we cannot diminish them. They produce a great effort. We in Iraq, we have already shortage in the hospital and primary healthcare center. Private sector support the hospital, do a lot of things. The hospitals are already overcrowded. If we close the private sector in the evening, in Iraq, where the patients will go, where the clients will go, but we need to organize. Definitely, I agree with you that there is some problem, overcrowded in some clinics, no triage, but frankly speaking, this is not only the problem of private sector, it's also the problem of many governmental hospitals and the primary healthcare center. It's not only the problem of the. So we need to change our attitude. We need to educate people not to what to do. It needs supervision, need rules, some guidelines to follow. We cannot leave the private, but not the answer is not to close them. Till where? It seems to be endless COVID-19. But we need to regulate it, put some guidelines. You know, for colleagues and for your Prof, do you know that each patient in Iraq, when he comes to the clinic or to the hospital, he will not go, at least there is one person, in the mean, the average will be 2 person or 3 with him. No one. So they come with accompanying people. They overcrowd the clinic, the primary healthcare center, or even the hospitals. So the private sector we cannot diminish, but we need to upgrade. We put some guidelines how to work. So not the cheater, those who do not do their work. But I think it's not the right thing for a long time. Maybe for.
If you allow me, I just received the data from His Excellency Dr. Ahmed Al-Mundari, our regional director of WHO, showing that the figure in Iraq is actually doubled in one day. Both number of cases, active cases, and admission. These are not detected because admission is doubled. So when you say we need, when? It's already too late. So when you're talking about the hospital have problem, primary care has a problem, it's managed by you. It's managed by the doctors, you know? I mean, you cannot blame, nobody can put fingers on the government. I'm not defending the government. I don't know the government. I'm not governing there. But you cannot blame government or Ministry of Health when the hospital is managed by a doctor, primary care is managed by doctors. If doctors in this institution, which I described earlier as your kingdom, are unwilling to act, you know, nobody will come from the space or Britain or any other country to act, you know. So this is a problem. Let me listen to Mehmet from Turkish perspective, because Turkey is one of the very few countries in the region separated between private and practice. There is no contamination between the two. And I know Mehmet on the enemy side, he's outside government. Mehmet, what do you think?
Yeah, this is very interesting, actually. You know, being a physician and being, how do you say, asking a freedom in your decisions, in your work style. You know, as a physician, you don't want the people to regulate you too much or to direct you too much. But on the other hand, we are all humans and we have different level of education and social beliefs also. And some of them are, you know, like the children, some of them are cleaner, some of them are not. Some of them are very, you know, active, some of them are not. The physicians are also humans, you know, we are changing. So I believe that, you know, the central, I don't know whether it will be an association, whether it will be the Health Ministry of Health, whatever, or regional directors, or maybe an association of the family doctors, whatever is that. There must be a very good regulation and immediately start to not do the work, but to check how the work is done. I'm not talking about the COVID. I'm talking regular visits to all private, you know, providers, let's say. Probably they do it for the hospitals. And in Turkey, we have very hard regulations for the family doctors working for the government, but also we have private doctors, physicians, specialists, and some other private clinics, private laboratories. Those are regulated very well by the government. And every month, without any notice, they come and check. And for if you have vaccinations in your private clinic, they are checking all them one by one, you know. So this is something out of the doctors it should be a kind of mechanism which we should encourage to make our job much better, to be audited by a kind of, how do you say, organization which may belong to yourself also. I think this is a good way of, I mean, not only COVID, but this is the good way of practice in the private sector.
I think, Mehmet, this is a good point. We have a question from an eminent colleague, Professor.
Salman, if you allow me for one thing
I'll
to
come
comment.
back to you. Let us, because linked to that. Faisal Nasser said, before we close primary care, you know, we need to think about continuity of care, which I fully agree with it. But continuity of care, to be very honest with you, from the European experience, was the easiest part to manage, because you can manage diabetic patients, you can manage people with hypertension, etc., online very, very easily. And it could be done by other members of the team, not family doctors, you know. There is also linked to that, one question in terms you need to actually, from Naim Al-Qasir saying in health emergencies, we discussed it, that we should bring the entire health system under one umbrella. This is precisely what Britain and other European countries did, and I think Canada did the same. How this is from, there is question from Dr. Fuad, asking about vaccination and some of the preventive measures. These could be easily done, not necessarily within the health center, within community centers by appointment. The key word here, and I must emphasize, it came from an eminent colleague's their practice, which is saying precisely that everything should be from now on by appointment, making sure there is no contamination between various patients visiting the clinic if face-to-face is allowed. Hassan, sorry, Dr. Hassan.
Yeah, thank you, sir. Thank you very much. Thank you, Salman. My point is that let us be clear among ourselves. We have a very limited number of public primary health care facilities in our region. Let us be more even specific. Egypt has 6,000 primary health care facilities. In Pakistan, for example, they have 11,000. In Saudi Arabia, they have around 3,000. Iraq, they have 3,000 something, maximum 4,000 primary health care facilities. No way, by any mean, this kind of, or this number of primary health care can 100% cover the entire population. Forget it. It will not happen with the maximum quality standards at this public primary health care. So when we're talking about that the private sector can be, for example, locked down or to close it because of the COVID, it will never, ever happen because they are providing majority of the service, most of the services. I'm talking serious here.
Because of the sloppy procedure. Because we're saying, and let me tease this issue a little bit further. We are saying very clearly, no COVID patient should go anywhere except to the hospital when it becomes serious. COVID patient, which is about 82%, maybe more, should stay at home. You know?
Who will decide about this?
This is documented. This is everyone.
Yeah, who will decide it? You are talking about our region here. Maybe in
it doesn't matter anywhere in the world. Mild cases should not leave home. We don't have any treatment. You know?
Theoretically, yes. Wonderful.
Where they go?
Yes.
Why should they go to primary care? Just tell me. Why should they go? Come on, carry on.
You can read these things very nicely, but when you work on the ground, it may very well be difficult to apply. I understand.
I spend my time here in primary care.
There are a lot of cultural things that we have to take into consideration. And I'll tell you from a practicing physician who works on the ground. When I do screening for patients over the phone before coming to my clinic, and I share the same experience of other physicians, and I have somebody who has sore throat and fever, and I tell them, you cannot come to my clinic before having tested. They refuse. They go to another physician or a third physician just because they want to avoid going to those places where they can get contaminated. The other hand, the same applies for someone who calls me and tells me, I have this, can I have COVID? And I tell them, okay, you can have COVID. Why don't you stay at home and then check how your symptoms evolve? No, I want to go, I want to be tested, and they become panicky. So the rule doesn't apply for everybody. When you work on the grounds, you have people who are ready to follow, but you also have people who do not want to follow. They want to do their own thing. And this is what we're dealing with in private practice.
But what do you do for some, I got fever and I got dry cough. What do you do for me? This is possibly 90% diagnosis as COVID. I'm your patient now. And I called you and you said to me, stay at home, take paracetamol, rest.
Yes, self-isolation and so on. You can go for this.
Okay. So why should I come to you and infect 10 people in my way?
Because they have this media who's causing them to be panicky. And they're worried about what they may get, what they're hearing about it, about those lung problems, about going to ICU, they want to know exactly what's going on with them.
Yeah, but you cannot verify anything, can you?
This is you and me saying this, but this is not what the common people think.
But why don't you inform the public in the proper way? Some of you are hearing on television saying the best treatment, stay at home. If you've seen the article in the Lancet today talking about totally different symptoms which appear in the early days of the disease, which if you just stay at home during a couple of days, you know, the viral infection will disappear, you know?
Yes,
it's beautiful from King's College, beautiful findings, you know? And I really want to push that issue in terms of why we force the people to go to places, you know, which are very dangerous places. If not infected, they will get infection. If they are infected, they will infect other. And this is how the virus is spreading.
Look, it is not we who force, it can be both ways, okay? If I have somebody who's calling me and wondering, okay, why don't you go to one of the COVID clinics and get tested if you're so worried? Mm-hmm. Okay? That's one thing about it. But you also have the other percent of people who want to get tested even if they have mild headache, mild nausea, because they read COVID can have these manifestations.
Yeah, I have a comment. We are extending it by 7 minutes. We were late, and I apologize. I echo your apology, our chairman, that we were late by 7 minutes. So we extend because we have a lot of questions and comments. Again, another comments from Dr. Faisal Al-Nasser, Professor Al-Nasser. We make family practitioner different from other discipline and the personal link between the patient and the doctor. So the issue is not only managing chronic diseases, etc., which is absolutely right. But what we are saying, Professor Al-Nasser, that relationship could continue without the physical presence in the clinic, because that constitutes huge danger. And I think this issue, Chris Van Wiel, which all of you may know from Europe, and president of WONCA, and I and other, we put it in the paper recently, the lack of public health experience in primary care actually did show the difference in this major pandemic, which is affecting all of us. The lack of training in infection prevention and control everywhere, at primary care level, at hospital level, it did show itself. And we are looking at something different. I just want toward the last minute to draw some lesson which we need to build for the future. What are the lessons which can we take from what happened until today for, number one, medical education, undergraduate medical education, And number two, for training our future doctors, whether in primary care or other specialty. But because we're talking about the primary care, let us focus on the primary care. Hassan, can I come to you, Dr. Hassan?
Yes, thank you very much. The way that I see it so far, Dr. Salman, then look back to what happened in March. I mean, all the region, they hit with the wave, the first wave. We wasn't actually prepared about this in March, completely. I mean, we all of a sudden, we became in the middle of this pandemic, primary health care, hospital, health sector, health system, everything, and we didn't know how to react. So far, we are in July, and we are talking about the second wave, which is expecting really to be serious in September. Yes. So my way that I see it really is that we have built some kind of capacity over the last period, starting from March until now, and we are in a very good stage to prepare ourselves in a better situation for the coming second wave. So the way that I see it, I am really happy that we already built very good capacity at the primary health care facilities. Some of undersecretaries or director generals, as I mentioned at the beginning of this pandemic, they didn't know how to react with what exactly is the role of primary secretary. Shall we keep it? Shall we open it? Shall we close it? How we are going to deal with the routine work? How we are going to maintain the services? So far, we already prepared for this. So the way I see that, definitely we will be in much better situation in September, inshallah, than in last March. Over to you.
Thank you. Ali, Dr. Ali.
Thank you, Professor Salman. First, I want to say that what we face in Iraq and many countries that the primary healthcare is not a priority till now. So we hope for the ministries, for the policymakers, they still think all thoughts in the hospitals and how to support hospitals. So we need to support primary healthcare. You ask about medical education. We have many challenges with medical education. We already enforced, as Dr. Hassan said, as we do regarding COVID. We have no other choice just to go into the e-learning. So we do something good, and we have some weak points we want to improve. We need to develop, because almost next year we should also go into medical education. Last thing I want to say that we lost a lot of colleagues in Iraq. Today we lost a neurosurgeon from Kerbala. He's a colleague. He passed from COVID-19 2 days ago. Also another one from Kerbala. We have more than 20 physicians we lost in Iraq due to COVID, and we are in the peak or going to the peak. It's a huge number of cases each day, as Dr. Salman. We are doubling the cases, and the test might not give us the real number. Death might give something more close. Thank you very much.
Thank you very much, Dr. Jinan. I give you the chance, and the last one will be Mehmet and Professor Khoja. Dr. Jinan.
I'm fine.
You're fine, Mehmet. Professor Mehmet.
I just say I am very happy to be together with you about the education. You know that like everybody in Turkey and in all around Europe, all carry to the web systems. Nothing to do for now, and unfortunately, those medical schools who are high, high level, like Imperial College, for example. Or those low-level medical schools, there is now not much difference talking about the views of the students. So I think in the coming years we will understand, if it goes like this, the developments and everything will be carried to the e-medicals, and the difference will be again apparent, I think.
Thank you. Professor Khoja, the last 30 seconds.
Okay, I just would like to bring that primary healthcare now and for long term should be ensured as the people trust, and leaders should invest in a strong family practice and also strong primary healthcare setup with high quality, and to make sure that it is accessible and very well equipped. Second, that healthcare leaders should explore innovative ways of delivering care through primary healthcare, like telemedicine and others modalities, in order to overcome issues like pandemic and epidemic. Thank you so much, Professor Salman. Thank you, everyone, and really I enjoyed it so much. Allah bless you.
Thank you very much,
Thank you.
everyone. And we definitely teasing our participant and our speakers in this sort of session, raising their adrenaline to get the full answers to the question and the debate. I'm truly grateful to you, Dr. Jinan, for sharing it, Professor Mehmet for joining us from Ankara, Dr. Hassan from joining us from Cairo.
Thanks a lot.
Ali joining
Thank you,
us
Salman. I really appreciate it.
And my dearest brother, Dr. Tawfik from Riyadh. Thank you very much indeed. And for those who participated, we apologize for the late start. We compensated by 70 minutes late. And also we apologize for not answering all your questions and reading your comments. There were many. We really appreciated your participation. And next week, we are debating something which is hot. Treatment of COVID. Some of it already, we touched on it, why people going with minor illnesses to primary care. But we have two guests, eminent consultant colleagues, one of them from United States, one of them from our region. And we will look forward to see you again next week. Bye-bye for now. Good night. Sleep well. Assalamu alaikum wa rahmatullahi.
Thanks a lot, Salman. Thank you very much. Thanks a lot, colleague. Thanks, Mehmet. Bye.
Thank you.
Bye.
Thank you.
Bye.
Bye.